Thank you, Sushma.
Thanks.
So we'll take our next talk by Dr. SUNEETA DUBEY. She's going to talk on surgery beyond tubes and traps, and are we, India, ready for beyond these tubes and traps?
And AIOC for giving the opportunity. As we know, traditional surgeries like traps and tubes have been successfully employed for several decades. However, they may be associated with sight-threatening complications. MIGS, being mostly conjunctival sparing, avoid the complications and relative unpredictability of the conventional glaucoma surgery. If you look at this glaucoma management spectrum, MIGS were designed to bridge the gap between the medical or laser therapies and more invasive filtering surgeries in mild to moderate glaucomas, especially if the patient is undergoing cataract surgery or the patient is allergic or non-compliant to the drops or cost is a factor. In this review article by Dr. AOIC2022, it was summarized that the MIGS procedures offer reduction in IOP, decrease in dependence on medical glaucoma medications with an excellent safety profile, and differs from the role of more invasive glaucoma surgeries such as traps and tubes. MIGS can be classified based on their physiological mechanisms and anatomical sites of action, and we in India have been now doing all these procedures which deal with the Schlemm's canal procedures and trabeculotomies. So basic mechanisms is targeting the site of maximum resistance and increasing the outflow through the conventional pathway. Just a word about incisional versus excisional. Goniotomy, which is an incisional procedure which has been primarily used to treat congenital glaucoma, and it works very well. However, it's an incisional procedure and often leave residual leaflets and scarring, and therefore not so effective in adults. As opposed, excisional goniectomy with trabectome and KDB excises the TM completely, and it minimizes the chances of scarring and re-occlusion of the collector channels, as remaining edges of the TM are far apart, and therefore it is effective in adult patients and across severity of the disease. Now coming to trabectome, it's a stand-alone device and utilizes a controlled plasma-mediated ablation system which removes the diseased TM and inner wall of Schlemm's canal. And the advantage with this standalone system is that it incorporates irrigation and aspiration. It pressurizes the eye and thereby increasing the intraoperative visibility and maintaining the anterior chamber all the time and managing the blood reflux also. And as with any angle surgery, the position and setup of the microscope is very important. So tilt the microscope towards the surgeon and rotate the patient's head away 30 to 35 degrees to maximize the gonioscopic view. Now coming to the surgery, these surgeries are generally performed along with the cataract surgery. So after having a good view of the angle, incision 1.7 millimeters given in the clear cornea, and that probe is advanced towards the angle. The trabecular meshwork is engaged with the tip of the probe and start ablating on one side. It should go very smoothly along with the arc of the Schlemm's canal without any resistance, and you can see this white line which is suggestive of the outer wall of Schlemm's canal. And as you keep rotating the gonioscope, you can target up to 140 to 160 degrees of the angle. And then you can go ahead with your phacosurgery. And this is another case of a child, and here you can see you're performing this goniectomy, and you see the the inner wall of Schlemm's canal, and you can see the outer wall of the Schlemm's canal. So when you perform the technique properly, you see this cleft post-operatively. Now coming to Cahook dual blade, it is specifically designed for the goniectomy. I'm not getting the cut here. So, so it has a sharp tip which pierces the trabecular meshwork, and the ramp lifts and stretches the TM, as you can see in the picture, and feeds it up to the dual blade, which creates parallel incision and excises the strip of TM. And the foot plate of the device settles within the canal. So there is no collateral damage. Now the surgery is more or less similar to as I had shown in the trabectome. This is the blade. Again, you target the trabecular meshwork, and with this blade you incise the trabecular meshwork and the inner wall of Schlemm's canal. And you see this trabecular strip here, which you can remove later or with the help of forceps or after doing the phacoemulsification. So you see the cleft again post-operatively. Now we have been performing this procedure bang with 25 gauge needle, and it's a very, very cost effective procedure. You just require this 25 gauge needle, and procedure is again the same, that you have to incise the trabecular meshwork. Although I feel it's an incisional thing, it may not be the excisional thing. And this is another patient where you can very easily incise the trabecular meshwork and inner wall of the Schlemm's canal to get this white line or the outer wall of Schlemm's canal. So now coming to GAT, which was initially described by Grover, and it has been done extensively at various centers in India also. And the suture GAT with 5-0-proline is very, very cost effective, and you can do 360-degree goniotomy or 180-degree. And I would suggest that initially to begin with, you can start with hemi-GAT, and unroofing of the Schlemm's canal is done with 25 gauge needle. And then this mushroom-tipped 5-0-proline suture is introduced into the Schlemm's canal. And the micro forceps, or the retinal forceps, is used to grasp the suture and advance the suture in counterclockwise direction along with the circumference of Schlemm's canal. So again, you should not meet any resistance here, and it should go along the circumference or arc of the Schlemm's canal very easily. And once you have done whatever you target, 180-degree or 360-degree, once you have done this, you just pull the suture externally and withdraw from the section, and thus incising 180 degrees of TM. So I would suggest that whenever you're doing these angle procedures, if you can demonstrate these fluid wave at the end of the procedure, wherein you see the blanching of vessels here, and you can ensure that you have made a connection between the anterior chamber and the collector channels. So I think it's important to demonstrate this fluid wave. Last one is eye stent, which is made up of surgical grade titanium, and it is heparin coated, and it is self primed. And this is the initial device, the single device. And now we have this eye stent inject, which comes as 2 eye stents with a preloaded injector. And I'll just show you the video. So after visualizing the angle, so you have to retract the sleeve so as to project the trocar, and so trocar has to be, you have to go up to the angle and place the trocar perpendicular to the TM and gently dimple into the trabecular meshwork, and you will get some bleeding here, and push the black trigger button. So bleeding is a good sign, and just move 2 to 3 clock hours away and inject another one. Just 30 seconds.
You have 1 more minute.
Okay. So once you have injected, you just visualize after clearing the blood, and both the stents are in good position. And this one is eye stent, the single device. Again, after doing phaco and visualizing the angle properly, you insert this device into the angle. So first you enter at an angle and then go parallel to the trabecular meshwork. And just check it by tapping on the snorkel that it is well in position, and then complete your IA. And so this is the post-operative positions of the eye stent, and it reduces, because of the paucity of time I couldn't discuss the studies, but there is definitely a scope of MIGS in the coming years, and there are now heterogeneous range of surgical options with the development of these novel surgical techniques. And we have a chance to tailor our therapy in an individualized therapy for a particular patient, especially in mild to moderate glaucomas. However, in Indian scenario, we need to do some RCTs to gather more evidence about the procedures.
Thank you, Dr.